Good afternoon and welcome to our webinar on protecting health workers while maintaining surge capacity. Countries are again being confronted with a surge in COVID-19 infections and hospitalizations. We are seeing in most European countries the second wave of the pandemic. And again, countries need to increase capacity. Scaling up health workforce capacity for COVID-19 patients is therefore of utmost importance. But scaling up is not good enough. Workloads, redeployment, upskilling, and fear of contagion puts enormous stress on the health workforce. Protecting the mental health of the health workforce while maintaining surge capacity is therefore of utmost importance. What are the strategies for expanding capacity? And what are the strategies for protecting the mental health of health workers? My name is Matthias Wismar. I'm the program manager with the European Observatory, and I'm today your facilitator. I will guide you through the program. Our keynote speaker today is Gemma Williams from the European Observatory. She will give us an overview on the strategies for expanding capacity and protecting health workers. She will also give us an overview on what countries have done and how they have implemented these measures. Gemma has extensively worked on COVID-19 and health workforce issues. Gemma's keynote will be followed by 3 spotlight speakers. They will zoom in on concrete country experience. We have lined up for you from Germany, Juliane Winkelmann from Technical University Berlin. Juliane will talk about changes in the regulatory context, new training and upskilling, and national and international recruitment. This is followed by Sandra Buttigieg from University of Malta and the Mater Dei Hospital. Sandra knows firsthand both worlds, the academic world and the world of service provision. She will talk about surge capacity for public health for testing and tracing. Small countries have particular challenges addressing the pandemic, and we're more than happy to have Sandra with us today here. Then we are inviting Susan Wood from the Health Foundation in the UK. Susan will focus on the mental health protection. She's currently authoring a blog on caring for our carers. What can COVID-19 teach us about NHS staff well-being? Finally, we will invite Gabriele Jakob. She is actually program manager for human resources for health at the WHO Regional Office for Europe, but she's also part of the transition team of the new regional director with responsibilities for change management. And I think that is very suitable for what we currently see in hospitals and other organizations. When we talk about upscaling and protecting capacity, let's make sure that we focus on the constructive bits. What can we learn from the evidence, in particular from the first wave of the pandemic, to respond more effectively to COVID-19 and the current surge of infections and hospitalizations? What have we learned from COVID-19 responses for strengthening health systems resilience in the future to withstand shocks and the crisis to come? Our time budget is very tight, which is a challenge for all our speakers. Just 3 things for housekeeping. Please send us your questions and comments through the chat box. My colleague, Erica Richardson, will feedback the chat to us towards the end of the session. We are also going to record this video and planning to publish it later on our YouTube channel. Finally, we will send you an evaluation form, and we would kindly ask you to fill it in, as it is very important to us to improve the webinar series. This is the 5th installment in a series of 8 webinars. Stay tuned and tune in again for the remaining 3 webinars on the coming Tuesdays, all at 12 o'clock. Before we start with the keynote, I've asked my colleague Erica Richardson, who's based at the London School of Hygiene and Tropical Medicine, to give us a 3-minute overview on the COVID-19 health systems monitor. We are monitoring COVID-19 responses in all European countries on behalf of the European Commission and WHO. This series of webinars is based on the evidence coming from it. There's also a special issue of EuroHealth and forthcoming a special issue of health policy. We'll keep you informed. And now let's begin. Erica, the floor is all yours.
I've got to keep this super short, but I just wanted to tell you a little bit about the COVID-19 Health Systems Response Monitor, which is a collaboration between the World Health Organization Regional Office for Europe, European Observatory on Health Systems and Policies, and the European Commission. The aim is for it with this platform is to organize and share information in 4 key areas. So this is the collecting, checking, organizing country information, comparing countries and setting them in context, linking to reliable and timely data, but also analysing key themes that cut across countries. And that's very much where this series of webinars comes from. So the user is able to go into the platform and select the countries that you're most interested in and the aspects of the COVID response you're most interested in. But you can also go in and see our ready-made cross-country analysis that pulls together the narrative threads. Now, the analysis section responds to questions from countries, from WHO, from the European Commission as they've arisen, but it also comes from the editors themselves, people like me and Gemma, who are spotting emerging issues and picking up on patterns and trends in the response in different countries. We like to provide examples and good practices, and we link to the key documents that you will need. And all of this analysis is updated as policy and practices evolve, indeed as the COVID-19 pandemic evolves. So thank you very much. Please do check out the platform, www.healthobservatory.eu, www.covid19healthsystems.org. Okay, thank you very much.
Thank you so much, Erica, for this concise overview, and thank you so much for setting the standards for keeping within the time budget. So without any further ado, I would like to hand over to our colleague Gemma to give us the keynote, the overview on scaling up the health workforce and maintaining the health of them.
So as Matthias has said, today I'm going to present an overview on the different strategies that countries in Europe have adopted to try and increase surge capacity during the first wave of COVID-19. And what I'm going to present today is actually based on 2 articles that we recently published in the latest issue of EuroHealth. So please do go and read them for extra information. And also the issue itself contains a whole range of articles on different COVID issues. So for both articles, we analysed data contained in the HSRM for 44 countries in the WHO Europe region, with the aim of identifying common trends across Europe in terms of increasing surge capacity during the first wave of the pandemic. And while timing did differ slightly for countries, it was generally, we took data from the end of Feb to the beginning of August. So before I jump into our findings, I'm just going to sort of take a moment to reflect on what surge capacity actually means, just for those that are new to the topic, and why this has been so important during COVID. So you'll see in the bubble at the top, I've taken a definition from the US Department of Health and Human Services, and they define surge capacity as the ability to evaluate and care for a markedly increased volume of patients, one that challenges or exceeds normal operating capacity. And the surge requirements may extend beyond providing direct patient care to include such tasks as extensive lab studies or epidemiological investigations. So to create surge capacity, it requires more than just available beds and equipment. It also requires sufficient numbers of health workers with the right skills to be in place. And so during COVID, we've seen that surge capacity was needed to meet an anticipated rise in demand for healthcare in acute and emergency care settings. This was not just in terms of numbers of hospital admissions, but also due to many COVID patients needing more intensive care and for a longer time period than a typical patient, especially in ICUs. At the same time, additional workforce capacity was needed in most countries to ensure that other essential healthcare services across all settings could be maintained while treating COVID patients, and to increase public health functions such as testing and monitoring and surveillance activities. However, during COVID, enhancing the availability of health workers has been complicated by a number of factors. So firstly, infection rates or exposure to infection has been quite high among health workers in many countries. This means that many have had to self-isolate or quarantine at one time or another, taking them away from the workplace. Practical barriers to working have also arisen. So for example, in many countries, schools were closed, meaning health workers had to find alternative childcare arrangements, while public transport, for instance, was also reduced in some places, creating challenges to actually getting to work. Importantly, health workers have been working long hours, treating and caring for large numbers of severely ill and dying patients during the pandemic. But first, with little knowledge of what treatments and care may actually be most effective. This has left them at high risk of experiencing anxiety, stress, trauma, and other mental health conditions. It is possible that this mental health burden may lead to burnout and force staff to have to take sick leave during the pandemic. And finally, creating surge capacity has been very challenging because countries actually entered the pandemic with pre-existing workforce shortages in many countries. So we can see from this graph here that with the exception of Germany and some of the Nordic countries, countries entered the crisis with lower numbers of nurses, lower numbers of doctors, or lower numbers of doctors and nurses compared to the EU average. And this graph is just it's a fairly simplified version of a very complicated issue. So it masks other workforce challenges faced by countries, such as geographical imbalances in the distribution of health workers, low numbers of specialists that were needed during the pandemic, such as ICU nurses or doctors and public health workers. So together, these created challenges for increasing surge capacity, making a complicated issue incredibly complex. So what then did countries do to try and create and maintain surge capacity during the first wave? So based on our articles, I've tried to group our strategies into two streams. And in the first stream, we had measures which were designed to protect capacity of the existing workforce. And I've defined this as health professionals who were already practicing in clinical settings before the crisis. And just due to time constraints, I'm not going to go into the measures in grey in much detail, but just to say these sort of covered things such as providing alternative childcare if schools were closed, or providing PPE to limit exposure to infection. The one thing that I will look into later on is measures designed to protect the mental health and well-being of health workers. In the other stream, we have measures designed to expand the capacity of the health workforce, and these measures could actually target the existing workforce, such as by modifying existing work practices, redeploying, reskilling and upskilling health workers, or utilising private sector workers in the public sector. Alternatively, they could target bringing additional health workers, students or volunteers into the health workforce. And I'm going to discuss these measures in blue later on in the presentation. So turning first to look at measures to repurpose, reskill and redeploy the existing workforce, we can see that most countries during the first wave took steps to modify existing work practices. So this included asking health professionals to work extra hours, for example, moving from part-time to full-time work or allowing extra overtime. Work schedules were modified. In some countries, rotations for residents in practice were suspended, or night shift or on-call regulations were suspended. Some countries cancelled leaves of absences, while others postponed re-registration or revalidation requirements. So I've taken some country examples that you can see in the bottom of the right screen, just to illustrate these in practice. And we can see that Greece officially revoked leave of absences for public sector staff. Romania suspended ongoing or scheduled external rotations for residents in training, while the Netherlands suspended re-registration requirements for physicians. Another strategy that was less commonly used was utilising the private sector workforce. And just as an example, in England, NHS England took over independent hospitals, which brought 10,000 nurses, 700 doctors, and 8,000 other clinical staff in to support the NHS. So in terms of reskilling, upskilling and redeployment, we can see that just under half of countries reassigned health professionals to other specialties, so particularly to work in ICUs or emergency departments, to other roles. So for example, we saw in some countries physiotherapists trained to work in acute respiratory teams, or dentists used to assist with sedation of patients in hospitals. And many countries expanded the scope of practice of professionals so that they could take on new tasks. And just as two examples, in Ireland, pharmacist license were expanded to renew prescriptions, while in Belgium, some nursing tasks directly related to COVID can now be undertaken by those not usually licensed to do so. And in about a third of countries, we also saw that measures were taken to redeploy health workers to regions or facilities with greater needs, so those experiencing a greater number of COVID patients. And in Italy, specialist medical and technical nursing units were established to recruit volunteer health workers. And this resulted in 300 physicians and 500 nurses being deployed to regions in the north that were experiencing greater need. Meanwhile, in Spain, regional authorities could assign doctors and nurses to different specialty units within the same hospital. And we also, in the papers, we tried to draw out some of the implementation tools that countries use to put these measures into practice. So to modify existing work practices, this often required the suspension of existing regulations or changes to contractual arrangements. Alternatively, emergency legislation, for example, to cancel leaves of absences or change registration requirements were needed. And all of these measures took great coordination between professional associations and national and regional health authorities. So to redeploy health workers to different disciplines, facilities, regions or cities with greater need, centralized or regional online portals were often created in countries, and these were designed to match supply with demand. Extra funding was often needed along with temporary contract changes, and additional training, either provided in person or online, was needed for certain health professionals to facilitate expanded scope of practice or greater task sharing. And to redeploy private sector workers to work in the public sector, emergency legislation was again required to enable public sector actors to take over private sector hospitals and staff. Greater coordination was needed between the private and public sectors, and the government had to provide funding to pay the wages or compensation to private sector workers. So moving now to look at strategies to expand surge capacity by mobilising and recruiting additional health workers. We see that the most common strategy adopted by countries was utilising medical or nursing students, either by allowing them to graduate early or to utilise them for basic medical tasks. Other countries brought back recently retired or inactive professionals. We can see, and this was usually done through national or regional calls for people to return or calls initiated by health facilities. We can see in Ireland, for example, they launched the National Be On Call for Ireland. This resulted to 72,000 people signing up to help and resulted in 260 nurses and 63 doctors being hired by mid-April. In other countries, exceptional procedures were launched to recruit additional health workers. This was done in Portugal, for instance, and they managed to recruit 137 doctors and over 1,000 nurses by the end of July. In other countries, measures were taken to try and bring foreign trained professionals into or back into the workforce. So in England, for example, doctors, nurses or paramedics with expired visas had them automatically extended. And just a last measure I'll talk through is support from international health workers was also used in some countries. And an interesting example is actually from Italy, where physicians and nurses from many countries were actually deployed to the worst hit regions through the European civil protection mechanisms. And in other countries, military medical support was utilised or volunteers were utilised in support roles. So turning again to some of the implementation tools that we utilised to enable medical nursing students to support the response, early graduation had to be approved. Graduates had to then be able to apply for provisional registration, and that relevant professional associations had to develop and offer temporary recruitment contracts. To bring in active or retired health professionals back to the workforce, national or regional recruitment campaigns were needed using traditional or social media. Temporary registers had to be created, and relevant professional associations or health authorities had to develop and offer temporary recruitment contracts. To recruit new health professionals, coordination between health facilities and regional and national governments were needed to report and assess demand and supply, and to match supply with where it was needed. Additional funding was needed from the government, while emergency legislation was needed to launch exceptional recruitment procedures. In terms of bringing foreign trained health professionals into the workforce, some countries reduced language requirements and waived fees for conversion exams temporarily. Emergency legislation was also needed to allow foreign trained doctors to work in support roles, and otherwise visas were automatically extended for foreign trained professionals if these had expired. So just quickly now to look at initiatives to protect the mental health and well-being of the health workforce. We saw that almost 2/3 of countries implemented measures to protect the mental health and well-being of health workers. This was mostly done through the implementation of helplines organised at the national and regional level by governments or by professional associations or universities. And these helplines were available so health workers could call for support directly or to find out where to be referred for additional help. And helplines were supported by apps or websites with chatbots in many countries, and this was to ensure that help was available 24 hours a day. In many countries, in some countries actually, guidance on mental health support was developed, targeting health workers or alternatively targeting employers. And in many countries, this was in addition to guidance that already existed. And in some countries, we saw that remote counselling sessions were also provided. And I'm not going to go into the country details, because I can see Matthias has given me a time warning. So I will instead jump ahead to the conclusions. And just to conclude, in our papers, we saw that multiple policy options at the national, regional and local level were used to enhance surge capacity of the health workforce during the first wave. Implementation necessitated emergency legislation, giving planners, providers and commissioners new powers, for instance, in terms of recruiting new workers or redeploying them to other areas. Training was needed to upskill health workers that were redeployed to other roles or had expanded scopes of practice. And additional funding was needed or digital tools, for instance, to match supply with demand. However, we currently have little information on how these strategies have played out in practice and the impacts they have had on workforce expansion, workflows, skill mix, quality of care and mental health. It is therefore important that countries evaluate the impact of these initiatives to inform strategies for surge planning and delivering effective crisis responses in the future. In addition, these evaluations can help to inform long-term health workforce reforms. So I think it's important to stress that while many of these measures are temporary, for example, modifying workforce practices, others such as expanded scope of practice and new roles may be important for developing the workforce of the future. And just as a concluding remark, providing appropriate long-term mental health support, adequate salaries and other compensation should be considered as core components of developing a sustainable health workforce in the future. So back to you, Matthias.
Thank you so much, Gemma, for this excellent overview on measures and also on implementation and on countries that have implemented these measures. I think it's very clear that there's a lot to learn from international comparison, and there's actually a real arsenal of measures for both, surge capacity, but also for protecting the health workforce. And I think we are going to zoom in a couple of countries and those measures to hear more of this. And that is why I would now like to invite Juliane Winkelmann from Technical University Berlin. Fill us in a little bit on Germany, Juliane. The floor is all yours.
Yeah, thank you for the overview, Gemma. I would like to briefly describe the expanding strategies in Germany. But before, I want to show you the initial situation of the workforce, health workforce in Germany. As you saw on the one figure Gemma showed, Germany has a very high level of nursing and physician rates compared to many other European countries. However, if we look at the numbers of nursing staff and per case, and especially in hospitals and in long-term care, Germany is far at the low bottom compared to many other European countries, which is due to a huge caseload, especially in hospitals, as a result of the high number of hospitals existing in Germany. So just to briefly describe the workforce strategies during the first wave, and then also I will go to the second wave. Many strategies focus on the modification of existing work practices, so part-time health professionals were asked to work full-time, and there were also in the first wave many nurses and physicians were asked to work part-time because caseload reduced. An important measure which is discussed a lot in Germany and based on emergency legislation, the minimum staffing levels in hospitals were suspended. And a third measure was the task substitutions by nurses and care professionals. So nurses were allowed to carry out curative activities. However, there's no evidence in how far this was really implemented. And a strategy we see now we saw in the first wave and now also in the second wave, hospitals on their own initiative, they provide training for nursing professionals without intensive care training experience on symptom control. The second group of strategies is the mobilization and recruitment of workforce outside the health sector. So there were many local initiatives to recruit medical students, volunteers, also retired professionals to help, mostly in ambulatory practices, hospitals, hotlines, but also many students worked there and volunteers worked in public health offices. In Germany, these are where the main player in the first and in the second wave to combat the pandemic, as they're doing the important tasks of contact tracing and testing. And then as Gemma mentioned, certain states, federal states, started initiatives to ease the procedure for foreign trained physicians to have a permission to work as medical assistants for a certain period. I just want to now show you what are the main challenges for the current challenges in Germany when it comes to the workforce in the health sector. As mentioned before, there has been a strained situation especially in nurses and long-term care professionals in Germany, and especially in ICU, intensive care units, long before COVID. And this critical situation is now becoming evident because nurses are absent due to illness or quarantine. So there is some redeployment of nurses within hospitals, and here in Berlin, for example, some hospitals are now starting recruitment campaigns to hire former or retired nurses and other health professionals. So they're really in lack of nurses to ease also to maintain the normal services, but also to ease the workload of nurses in ICUs. In October, one initiative or one step by the government was the increase of salary of nurses working in public hospitals. And as I mentioned, there's also a lack of health professionals and staff in public health services in the public health offices. Also similar as for the nurses, this has been there was a lack since several years. Due to low salary compared to the health sector, and the government now promised to create 5,000 new jobs until 2022, but which is not a immediate solution for the lack of staff now. So currently, the armed forces are helping out in the public health offices to do contract tracing and testing. So I can highlight some other issues here, but I think. These are the most important challenges for Germany.
Thank you so much, Juliana. I think that was very good and very interesting, and also very important that you have been challenging a little bit the figures. You know, the large headcount doesn't actually mean that the right people are at the places where we need them in the pandemic. You know, it doesn't help to have a lot of hospitals and beds if we don't have the workforce working there actually. And also, thank you so much for pointing out a little bit towards the resilience, you know, what we can hope to retain, that we have a little bit of an upgrade of salaries for ICU nurses, and that we employ more public health workers in public health offices. So that's great. And now we move to Malta, and I would like to give you, Sandra, the floor.
So hello, everyone. In this very short presentation, I will focus on the public healthcare professionals community in Malta. And the reason being that this is the first and most effective line of defense, with Malta being a very small country, very densely populated, and with limited resources. By no means am I forgetting my most esteemed colleagues in primary, secondary, tertiary, rehabilitative and geriatric care across the Maltese healthcare system for their contribution in responding to the COVID-19 pandemic. So Malta, as I said, small country with a very small population, and it is very important to look at the background, where we started, where we are today. And in describing Malta's experience in COVID-19 response is divided into 4 phases. So the first phase was before the first case actually was diagnosed as positive, and that was before the 7th of March, when we had the first case. We had a great deal of fear of the unknown, and all this pressure was largely contained by the public health community, and trying to prepare for what is to come, and listening to the news coming from mostly from Italy, and the deaths that were actually the deaths in Italy was quite alarming and overwhelming to the Maltese population. At that time, we were focusing as a public health community on people who were traveling out of Malta and back again, or else being out and coming back. And this was pretty overwhelming. We needed to set up the helplines for the public, but also a separate helpline to also answer questions from healthcare professionals. Then the second phase. And in the second phase, we can see that we did absolutely very well. And we, of course, the public health community was the voice to the public on COVID-19, but also by means of the superintendent of public health, we had the person who was negotiating with the cabinet, with the ministers, and with everybody to actually plan and contain the pandemic. And this worked very well. As you can see, we did very well. Then summer came, and in the first 2 weeks of July, we actually had pretty very low numbers and on certain days, 0 new cases. And that led to the government releasing the restrictions. May I remind you that the partial lockdown started on the 28th of March, and on the 4th of May, we started releasing. Now, this was in line with public health advice. And as a public health community, we felt that our advice was being heard and heeded. In summer, when the release of the restrictions came along, the public health community was quite alarmed because, of course, this happened so quickly, and we were envisaging that serious consequences will actually come along. Then we had the situation we are in today, where, as you can see, things started to really go haywire with as you can see, critical cases in the intensive care unit and fatality rate rising, etc. So I would like to say that the infectious diseases falls under the control of infectious diseases and prevention of infectious diseases falls under the infectious diseases and control unit, which falls under the Directorate of Health Promotion and under the Superintendent of Public Health. But of course, we had huge challenges and we needed strategies for this. And the main cause is the high pressure from policymakers in heeding public health advice. And therefore, there was always the public health advice and economy trade-off. And we were insisting as a public health community that unless the health of the public is protected, you cannot have a good economy. And this sort of trade-off and pressure from both sides was the main cause for so much frustration by the public health community. that led to some of the other problems. Of course, the interaction between and within departments across health system was another challenge. The redeployment of healthcare professionals, as already stated by other speakers before, the retraining, reskilling to protect and expand capacity. We needed to change work patterns, working shifts, rosters, also the notion of team building. As we know, teams need to be formed, and there is also the process of storming, norming until we become well-performing, the use of technology. So much we needed to learn with regard to, for example, WHO Go data, the use of virtual meeting technology, etc. We also experienced high turnover with input from medical students, new graduates, and those in training. Also, a challenge was dealing with the public. And we needed also training on that, because at times we had to deal with public who were anxious, sometimes arrogant as well. This led to some of our colleagues actually experiencing emotional exhaustion as part of burnout, work stress, and psychological strain. And however, we really had some words of encouragement, like the one from Hans Kluge congratulating us on the first wave. What were the positive outcomes? And I think this is really nice coming out from the public health community. Even though we're faced under such a huge pressure, the public health community got closer together. We started talking to each other. In the past, we were in silos. We organized ourselves into teams. And here I'm showing an organogram of how we could organize ourselves into teams and communicating with each other, having meetings to actually have visibility of information.
Sandra?
Yes, I'm finishing. The improved communication and definition of roles. We wanted the well-functioning teams to become resilient, as stated before, the support from psychological services. And last but not least, also celebrating success. When we're doing good, we started to also celebrate success. And I think this is basically, as a public health community, again, Hans Kluge was actually encouraging us. And I think one final comment is the increased recognition of the relevance of public health as a specialty has really come out as a positive outcome of COVID-19.
Thank you so much, Sandra. I think that's quite a fascinating story, actually. Also, the surge capacity needed for public health and for tracing. And thank you so much for giving us a little bit a view behind the backdrops, the background that we can see, the conflicts, but also the collaboration between different departments, working across different sectors and working together. And I understand from you that this is actually something which is more of the kind of governance and the collaboration, which we hopefully retain at least some aspects for the future to better address whatever challenge we have. So thank you so much. And now I would like to move on to our colleague, Susan Wood. Susan, are you there?
Great, so I'll get started. So as Matthias said at the start, I wanted to really focus down on kind of staff wellbeing for my few minutes and share two practical examples from England where we've seen organisations prioritising mental wellbeing of staff in two really different contexts, but which I think provide some really good insights about how organisations can focus on wellbeing in a way that helps them cope with the kind of current crisis, but also shapes how we can think about and prioritise staff wellbeing in the future. That, COVID didn't create some of the workforce challenges. And, we see from that 40% figure of staff being unwell as a result of stress from our annual staff survey, those challenges were already there, but they were really exacerbated and I think added to by COVID. And while we won't know the full effect of COVID on the mental wellbeing of staff for some time yet, I think the examples I share might be helpful in thinking about how we can think both in the short term about the support that staff need for their mental well-being as we continue with this kind of global crisis, but also how we can think to the future about what might be helpful in kind of mitigating and reducing some of the damage that could be caused by that. So the two examples I want to share are from different ends of the country. So starting with Northumbria first. Northumbria Healthcare Trust is a large provider of healthcare services in the north of England. It provides hospital care, but also a wide range of community services over around 12 sites, so quite challenging in terms of staff engagement. Northumbria had invested a lot in thinking about staff wellbeing and staff experience beforehand, and they were quickly able to kind of pivot a project that the Health Foundation had been funding to turn it into the Corona Voice. So Corona Voice was quite simple. It was a short weekly survey of staff morale, but also gave staff the opportunity to kind of provide comments, feed in concerns, give feedback. And really importantly, I think they would publish weekly, they're really transparent, but they also informed the organisation's response to COVID in some really key ways. So PPE was one really clear example where staff reported that not only did the shortage of PPE put them at physical risk, but it was, causing quite a lot of anxiety and stress amongst staff. So knowing this, Northumbria was able to get ahead of the curve, source a local supplier to ensure that they could address that issue for their staff. Similarly, I think it was also really important it allowed them to tailor their response and not just see, staff support or staff wellbeing as a one size fits all. So, for example, staff who were perhaps at more risk of COVID, a natural way of protecting them physically would be to enable them to work from home or to shield. But they were able to see from Corona Voice that those staff were feeling quite isolated and disconnected and actually feel feelings of guilt about not supporting their colleagues on the front line. So they were able to put in place a tailored package of support for those staff, regular phone calls, ways for them to connect with their teams and ways for them to feel part of the wider effort that had a really big impact on morale. So one of the reasons Northumbria was able to respond so quickly was because they'd invested in this before and they'd built up trusting relationships. So turning to the south of the country back in London, the Nightingale was very different. It was one of the field hospitals set up to help the NHS cope with the predicted demand for intensive care beds. They didn't have the advantage of those trusted relationships of infrastructure, but the team setting up Nightingale really focused on wellbeing and experience at the heart of their approach. And while many of the things they did were really simple, and some of the things that Gemma outlined before around mental health support were there, they were really underpinned by a focus on psychological safety and a real focus on listening to what mattered to staff and putting in place things to respond to those. So one thing they did, I think really exciting, was a new role of a bedside learning coordinator. I can share some papers on this. This person was the eyes and ears on the ward when managers couldn't be there in the ways they might otherwise be. And not only could they identify sort of some really practical things that could be fixed to help improve staff experience, like having clocks because people couldn't take their watches or phones into the ward, but they could also see and identify when staff might be struggling and need additional support. Like these were often quite simple, but making sure someone had someone to have a cup of tea with at the end of a shift, chance to talk and share. The bedside learning coordinator role is being rolled out in other hospitals in the UK because I think people have seen the benefits it could provide, not just in these really extreme circumstances, but in terms of supporting kind of longer term the wellbeing of staff. And I think I'll stop there, but I think that some of the things that we can learn from those examples I've shared are really starting to infiltrate some of the conversations we're having at national level, organisational level, and individual level about what's really needed to ensure the well-being of staff long term. Thank you.
Suzanne, thank you so much. I think I take it from your presentation, and I think that echoes what we've heard before, that the COVID-19 pandemic has laid bare deficiencies of the system for the health workforce, deficiencies health workforce advocates and researchers were talking for decades actually about it. So I think that's very important to acknowledge. And second, I take a quite positive message from you, because what I see is relatively simple and straightforward tools and changes, which can already make a change and which can help to change communication and address some of these issues. So it's not rocket science, but it's very interesting activities. Thank you so much, Suzanne. And now it's my great pleasure to invite Gabriel Jacobs from the WHO Regional Office for Europe to act as a discussion and reflect a little bit on what you heard so far, from Gemma's keynote to Suzanne's zooming into the nitty-gritty of Northumbria and the Nightingale Trust. Gabriel, the floor is all yours.
Thank you so much, Matthias. Good afternoon, everyone, and thank you for this opportunity. I think this was extremely rich, and this is a tall order to reflect in the time available. I think the very first thing I'd like to say is last week, the World Health Assembly unanimously endorsed a proposal to declare 2021 as the International Year of Health and Care Workers, and to acknowledge, as an acknowledgement of the efforts that health workers are making on all our behalves to tackle the global pandemic. And I think this is a real opportunity for us all in the health workforce community internationally to really support the health workforce for the future. So I just wanted to start with that piece. Julianne has very clearly shown us that the health workforce is a valued but limited resource, and we need to ensure that we're deploying them where they're needed most in a way that makes most sense. And I think as we move forward, that's something we will need to continue to think about in terms of dual track approaches. I was very interested in what Gemma had to say in relation to the modification of existing workforce practices. But I do note that, coming back to what Matthias asked at the beginning in terms of lessons for the future, this is perhaps not long-termly sustainable for the long term, particularly things, for example, around things like cancellation of leave, because that has an impact on the mental health burden of health workers. So we will need to think about what we take forward with us from the pandemic, from that first wave, as we move forward and try to maintain a dual track approach for services. Evaluation can really assist with informing long-term healthcare workforce changes as we institutionalize for the future, including the supports that are required to enable some of these shifts to be made for the longer term. I really welcomed the message around the coordination between professional associations and national and regional health authorities. That's very welcome. And in terms of shifts for the future is extremely important. In terms of overlooked discipline areas, I would also add occupational health to our list. So I heard from Suzanne in terms of the work that's been done in the Nightingale in Northumbria, and from Sandra. And occupational health is maybe something we've overlooked a little bit in the past, but we really need occupational health to help us for the future in terms of supporting our health and care workforce. There's general applicability of many of the workforce availability issues that Gemma referenced at the beginning of her presentation. Those are underlying issues that we still need to continue to figure out how we address together. In terms of Sandra's presentation, perhaps something that we need to come back around on a little bit more and to understand a bit more is the team building aspect of all of the new teams that we built during COVID. Because as colleagues mentioned, we enhanced ICU capacity, we repurposed colleagues, we invited colleagues back into the workforce. That team building is critical for effectiveness. And I'd like to learn a little bit more about the Maltese experience. In terms of mental health and psychosocial supports, we already knew this was a big drain for health workers, and this was a big challenge, and COVID has only amplified that. Certain groups are more effective than others. So, for example, staff who've been bereaved personally or professionally, those who are already in disadvantaged cohorts, other groups. So we do need to think about a nuanced approach to how we address the mental health and psychosocial supports that our health workers need. I really liked the focus in the Northumbrian work in terms of the regular pulse survey. And in the surveys, the webinars that we've been running in the regional office on mental health and psychosocial supports, that ongoing engagement and trusted engagement with staff is really, really important. And I think one point just to mention is, particularly where there's a separation between the health workforce and the care sector, it's very, very important that we embrace care workers as well. And we have seen examples in the European region of existing approaches, not health approaches, wellbeing approaches being extended into the care workforce, because we do need to support the totality of our health and care workforce. And just to finish on Suzanne's point in relation to the focus on psychological safety, I think what I'm hearing from all of this is it's time for us to be human with health and care workers. We're all in this together. And I think that humanity and recognizing that is extremely important as we design policy solutions, both for the short term and for the medium term. Thank you very much.
Gabriele, thank you so much. And that was really great. I mean, you've been saying these were rich presentations, but your contribution was also very rich. I take it from you that not all of the measures we have seen lend themselves for long-term sustainability, actually, even though we are all hoping there's a little bit more flexibility. Coordination will be something which is very important for the future. You mentioned occupational health and, of course, the team building access. Erica, what do we have in the chat box? Please, at least one round. You need to unmute.
Okay, there's so much stuff in the chat box. One of the things I really want to say is thank you for everyone for engaging with this so well. One of the main things that came up is that people really want to focus on nurses, which is something that really pleases my heart. Also recognition of other neglected professions such as lab technicians. But But really, I would say for this round of questions, something that's come up in different ways in lots of different questions is the challenge of reskilling retired professionals or training volunteers and students. What do we do about quality of care? There are concerns about quality of care. There are concerns about malpractice and how we would even deal with that. And also the risk of overburdening student nurses. So that's one round. And also, please do respond to each other. But that's very much a big focus for one round of questions.
Gemma, maybe you want to start?
Thank you for asking them. And just to pick up on a couple of the points. So I think the malpractice issue, actually, that's popped up in a few sessions that we've done. We don't actually have any examples from Europe, but I do know that America have actually launched some initiatives to try and make sure that health workers are subject to less malpractice pursuits during COVID than they were previously. So that's perhaps something that European countries could look into. And in terms of reskilling, I mean, this is such a long-term issue that people have been trying to work on to do properly. So I think will be a huge focus going forward. And just in terms of COVID, I think it's not necessarily a case in every country. I think some countries have done better than others in terms of providing the necessary support and skills to people that are brought back to the workforce. And just to say that oftentimes actually in the UK, for example, when older sort of retired professionals were brought back, they weren't put onto the front line because of fears over their own safety. They were put into other roles, say, for example, to help man helplines or to support GPs.
Thank you so much, Gemma. Juliane.
Yeah, just on the issue of malpractice, I mean, this is often, I think, also a result of the policies that have been implemented ad hoc during the COVID. For example, the increase of working hours, the upskilling, of course, and the suspending of minimum staffing levels. So this may create other adverse effects, which we are not, I mean, we are aware, but there's no evaluation on it. So just to keep this in mind for the coming years.
Sandra.
Two things. The first, the increase in the practice of telemedicine and virtual consultations. That raised quite a bit of, I would say, anxiety by professional communities, because of course we haven't been prepared for these until COVID actually came along. So I believe that now COVID should help us to prepare better in getting telemedicine up, better regulated across all the professions. I think of course, you've mentioned the notion of volunteers. That is my second point, because it is fine to get people on board. It is fine to get people out of retirement, to get medical students and other professions to join in. But we need to make sure that these will be assets and not liabilities. And the third point is moving people out of their comfort zones, out of their silos. Especially, for example, I've shared this with you, Matthias, we've had ophthalmologists moving out of long years of being in ophthalmology to the emergency department. And I'm sure they were not in their comfort zone, but we needed human resources to actually function better outside their comfort zones.
Thanks a lot, Sandra. Suzanne.
Yeah, I think just picking up on Sandra's point, I think we've seen some practical examples. I think Nightingale's really good about staff coming from all over the place with completely different backgrounds and skills and not knowing each other. And there's some really practical things as well that really help them. So having buddying system for staff, something about being really open and honest with staff up front about what they were getting themselves in for. So Nightingale was obviously in a massive big conference centre, but putting in place simulations so staff kind of knew what the environment was. So not just going, oh, well, they're this sort of doctor, they can just slot in there, but just paying attention to actually how that really different circumstance and contacts can impact on people.
Thank you so much, Gabriella.
Thanks, Matthias. And picking up on the previous speakers, I think for me, the core word here is supports. What are the supports that we make available? Because they're critically important for encouraging people to leave their comfort zones, to be effective in different roles, to feel supported in those roles, and to minimize the anxiety. So for me, it's about getting those basics right. And some of them are small things, but a buddying system, for example, is really important to the people who benefit from it. So I think we need to drill down to some of these micro examples and share them because they're extremely important for building teams and bringing people out of their comfort zones. Thank you.
Thank you so much, Gabriel. And Gemma, just to finish this up, I would have a question for you. Are we actually making good use out of a very bad crisis? Are we retaining something which will strengthen our health system? And also, are we retaining something which will improve the situation of many health workers? Because we've heard about the difficult situation, not only of nurses, but also of many others rather neglected health workers.
Yeah, I think this is an excellent question and was actually going to be something that I sort of reflected on in the wrap up, that I think COVID really has brought to the forefront sort of many of the issues that people have been struggling with in terms of the health workforce in recent years, and many sort of innovative solutions have been put in place during the pandemic. And I think we need to have really a long reflection on what the legacies of these pandemic responses will be. So, for example, will we turn them into better joined up health workforce planning in the future? Will there be more focus on skill mix and task shifting in some countries to try and build a more sustainable sort of domestic workforce? And sort of importantly, through this session, I think we've seen will there be more effort to support the mental health and well-being of workers and to sort of improve salaries to improve retainment? And I think at the moment, this is all to be determined. I mean, it's far too early to answer this question at the moment, but they're questions that we really have to have at the forefront of our minds and in our work as we go forward.
Thank you so much, Gemma. Thank you so much for helping us getting our mindset on the question, which are very important, pointing into the future. Thank you so much to all the speakers, spotlight speakers, discussant. Erica, thank you so much for managing the chat box. I think that was a very rich, very good discussion. And I hope that the participants, the attendees have been benefited just like we did, I guess. And thank you so much. And tune in next Tuesday. Bye-bye.